to it and select the camera again because you have to go to the settings and switch it and
Okay. Okay. Can you please give me the list of diseases that are in your book? I know there is achalasia, so I can follow up on it right away.
Crest syndrome.
Achalasia, crest, scleroderma, Barrett's,
Cancer and varices.
cancer, Zanker,
Shinsky ring.
varices.
Any shots get the same thing as Zanker's?
No. Anything else?
Plummer Vincent.
Plummer Vincent,
Esophagitis.
Mallory, Weiss,
Burha.
esophagitis,
GERD.
GERD,
Burha.
and what else?
Barrett.
Barrett, I have.
Burha Shabazz.
Borhov,
Mallory White.
yeah, I have that. Bichette, it's a, you know what language is that? Yeah.
You have esophageal varices.
Yeah,
Burha Shabazz.
Chagas disease,
And curling ulcers and hiatal hernia.
and hernias.
And ulcers.
Chagas.
Chagas, okay, good. Let me see, out of these, I want to talk about achalasia, GERD, together. Can you make them into this group so I can follow them because I'm going to erase this. So I want to talk about achalasia and GERD together. And
Esophagitis and varices.
no,
Mallory Weiss.
Barrett's. And add to this, that's 1, 2, 3. And add to this esophageal stricture, that's 4. Esophageal stricture. And Zanker's diverticulum. Cancer. In cancer, sorry. So you go 1, 2, 3, 4. Bichette, Borhoff. Yeah, that's good. So I want to talk about these ones together. Okay, so just please write them down together. These 4. Esophageal cancer, Barrett's esophagus, achalasia, and GERD.
What was the one like that?
Stricture, esophageal stricture. So let me erase these. And then the next one, let's say Borhoff. Borhoff. Esophageal varices. Mallory Weiss. That's the next 3. Okay. Okay. And then let's say crest, scleroderma. And let's say plumber, no, let's leave it. Crest, scleroderma. Bashet is not even common, so who cares? Yeah, I guess I can do this. Zanker diverticulum, the rest I'll do it. Okay, so that's fine. The rest I can do separately, yeah. All right. What was the first one? Achalasia, right? Achalasia. And then cancer, esophageal cancer. I mean, I'll put GERD right immediately. Let's put GERD. GERD. And then we had esophageal cancer, right? Okay. There's two more, but that's complication of GERD. So we can do it. Okay. All right, again, remember your quiz today is about underlying causes, right? So at the end of the class today, I'll do that. So hopefully by then you have a little bit more ideas. But meanwhile, I can pick on you. Achalasia. What's the underlying cause of achalasia? Okay, myenteric plexus deficiency. So what? Okay, so it's LES that is defective, right? LES is closed. It doesn't open properly. So LES does not open. LES does not open. And GERD, what's the issue? Okay, so LES stays open longer than it should. Esophageal cancer, what's the problem? There's a mass. So, there's a mass. Okay? Now, so now I'm talking to students more one-on-one. I'm getting the ideas. We have to focus on what are the goals of me teaching. What are you trying to get out of this? So at the end of each class or in the beginning of each class, please don't leave unless you ask me and unless I tell you what I expect you to know. You read a whole disease and then at the end of the day, you don't understand it. So what's the point? You have to tackle this issue differently. Okay? So please remind me at the end of each class or in the beginning, especially at the end, because once I cover something, then I know what I have covered and what is it that you want to get out of it. Okay? So the objectives of each class, each lecture, at the end of that lecture day, I have to tell you. Don't go home. Again, I'm going to forget. This is your responsibility. Please, somebody should remember. Objectives of today's class. Don't go home until I tell you the objectives of this class. What are you expected to know? What should you understand? Okay? All right, and you have to do that today. Once you go home, make sure you study those objectives today. If you can answer those questions, you should be fine, at least to some extent. When it comes to students, there's two things. One is you have difficulty remembering things. That's one thing. The second one is you have difficulty applying it. See, memorization does not require understanding. You can memorize things. Some of you might be good in memorizing. But you need to know both memorizing and application. For memory, you have to repeat over and over and over. For memory, you have to repeat, not reading 20, 30,000 books. Again, I'm telling you, if you want to memorize, repeat over and over the same thing over and over until you get bored of it, and still, if you don't know it, keep going. Now, for understanding, you need to calm down and relax. No life stresses. And just think about it. How could you use that to benefit yourself? If you think about it, and whenever you read a question or something, put yourself in that case scenario. Make yourself the victim. Like if I'm having difficult swallowing, I'm having achalasia, so how would I feel? How would I act? What can I do to relieve those symptoms? What could I do to diagnose them and see them and find out what's wrong? You should have those questions in your head all the time. That's what makes a successful doctor, a curious person. Curious George, there you go. Otherwise, honestly, if you're just, then, the impression that people will get, including me, that you're only here for what? For money. You just want to get that status and money. But to get it, honestly, you have to act like a physician, and you have to think like one, even though you're not there yet, but you have to start thinking like that now. Your priority, you need to change your mentality, even though it's nothing wrong with it. Trust me, I went to the business for money. Okay, good for me. Nothing wrong with it. I'm not saying that's wrong, but it wouldn't help you much. There's a better way of you succeeding, and that is if you care for medicine itself. You really have to care for medicine itself. You have to take your own personal feeling away from now. Because when you do, you'll automatically come with a solution yourself. Each one of you is equipped with tremendous amount of tools. But please use them. If you don't use them, you put them in some corner of your head and you just lock them, you won't get anything out of it at the end of the day. You'll be just staring sometime, you'll be looking, you'll be doing, you think you know it, but you don't. So you do have to be concerned. If a person has esophageal cancer, do you even care? You don't have to care. It's not legal for you to care. But at least for you to get to that point, care now. Act like you care. When you care, imagine, think about it this way. If one of your relatives, the person you love, has esophageal cancer, what would you do compared to somebody you don't even know? Yeah. You will spend the go. And you will come and ask me questions because you do. When your relative or somebody, a friend tells you, you come immediately ask me questions, this. This is what you have to do with every single condition in this course. Every single. Because at the end of the day, you have to be equipped to diagnose people. Okay, so just internally, not to me, internally show concern for yourself. Just be concerned a little bit about each condition. What is it? Why is it? What can I do? What can I do to cure it? What can I do to resolve it? What can I do to diagnose it? How could I recognize this condition based on symptoms, based on pathology? What are the risk factors? What are the triggers? What can increase this? What could decrease it? These are genuine questions. Any human being who wants to be a physician, again, who wants to be a physician for the right cause, would come with these questions themselves. I don't have to tell you that. All I need to, honestly, a professor only tells you one thing: what caused this condition and how it comes into place. The rest you can figure out yourself. Let's practice it today. Hopefully, it will help you. Again, at the end of the day, I have to equip you. You don't try copying me. It won't work. I have to give you the tools. Once you have the tools, you're self-sufficient, then you can do it. Okay? So stay away from memorizing in the wrong way. Memory is important because only for you to understand these things. So try to use the tools. Try to stress yourself. And I keep saying that I think you guys are too blessed. And that could be, too blessed means it's a good thing, but at the same time, it is not a good thing. You guys are too spoiled. Too spoiled. You really haven't come at any hardship. Something slightly hits you and you get nervous and stuff. Slightly. You go to those areas where I lived, and some of you probably come from those areas. Your parents came, you guys are probably young, and people don't even have food. People have to deal with so much stress. And they're able and they're stronger to deal with it, and they can go on daily basis. Their parents are, their parents are actually getting killed in front of their own eyes. They're being abused in front of their eyes. Sometimes a person have no limbs, they come to their parents, and then they have no doctors, and who takes care of them? People who have no education like you. You have warm water, beautiful food, clothes. I don't know, what else do you want? And still, you have trouble? That means you're spoiled. You're not blessed in a sense. Please take advantage of what you have. You're in an incredible position. And you can do so much. You have so many opportunities. This is the only country where we have the best opportunities, honestly. I don't care what you guys think. It is the best country on earth in terms of standard of living. People have natural inclination towards where they're born. Like they're like, oh, my country, my country. Then how far are you going to go? What if you're born in a hospital? Are you going to love that hospital? No. If you're born in let's say, in Little Company of Mary, and you get a job in Northwestern, you're not going to go to Little Company of Mary like, okay, I was born there, I love it, I'm going to sacrifice. They give me more salary, forget it. And it's a better hospital, forget it. You're not going to do that. This is the best country, and it gives us too much opportunities. Please take advantage of it. And have a mentality of, and I'm telling you, please do this. Have the mentality, never complain. Never complain. When you complain, your brain accepts it's weak. When you don't complain, you're going to find a way to resolve it. Don't complain and don't have excuses, no matter what happens. No matter what happens. We have this story that there was a ship that was sinking, and the person is sitting and he keeps going to the corner that is the highest, that will not sink, and he's still studying. He's like, well, at least I have 5 seconds. I might as well gain some more knowledge. If I'm going to die, I'm going to die. It's not like, he had no hope of saving himself. So he accepted it. But at the end of the day, you have tremendous opportunities. Each one of you like a prince, like a king. You have beautiful jobs. Those of you have jobs. Those of you who don't have jobs, you have parents taking care of you. You have everything on earth. Everything. There is no excuse for you. There is no excuse. So if you're still getting low grades, you need to fix. You need to fix something. You need to fix your mentality. You need to move on. And as I said, by the time you realize What did Asim tell you, Nina? I don't know why I'm picking on you.
Yeah,
It's not picking on
he
you.
told both of us.
What did he tell you?
Review course, if you don't take advantage of studying now,
Yeah.
it's
Yeah,
real
he said-
fast paced and it's hard to
If you
keep
don't,
up.
yeah, if you don't have everything down now,
Yeah.
later you don't have chance to go back and learn. That's
Yeah.
just review. It's way too fast.
You want to do 2 years work in 3 months. That's the review course. Why is it called review? It's not called a studying course, review. And then you want to take this exam on a single day. 9 hours of sitting in front of the computers. Okay? Is it difficult? I don't think so. So don't get scared. You know why you should get scared? Of your own behavior. Don't get scared of the external things. And you know, no matter what I put at you, no matter what challenges I give you, you shouldn't be afraid of that. Be afraid of you not doing the right thing. Okay, so we're designed, you know, like the culture and whatever, the way we grow up, unfortunately, we always think of external sources as an excuses. We put all the blame on things outside of us. Fix your own mentality. You will succeed in one day, and I believe you will have no problem. Now, Dr. Musab is trying to get you guys into research and get you to bigger hospitals, and with other university and communicates, you have to have knowledge. You have to have knowledge. You know, every time we try to do something, but at the end of the day, you know, you have to be qualified to go there, because you're going to represent a school, a community, you know, all in yourself and me and in him. You have to, I mean, seriously, you judge. And it's the right thing. How do we know what's good and bad? We judge. You make comments about other people. You make comments about other schools. You make comments about other students. You can make comments about each other. And it's fair, because what you see, you don't know what's in people's heart. You only make judgment based on what you see, how you interact. When you go to those places, when you go to clinicals, when you go to hospitals, they're going to judge you based on what they see. Nobody's going to know your beautiful brain and heart unless you express it. Okay? Unless you express it in a way that is feasible, that is acceptable to certain communities. So you do have to change. You do have to change. And I'm telling you, you guys are too relaxed. Too relaxed. I don't know why. You guys are so relaxed. It just bothers me sometimes. It really bothers me, you know. I'm not saying you should be stressed. Stress is simply an alarm to alert you, do something. Do something. Okay, but we're too relaxed in terms of we give priorities to other things. This is the only priority right now that you have, in my opinion. If this is not a priority, something else, then maybe you should take a break. Because everything that's priority have to be resolved first, right? The fact that you're sitting here, I know this is your priority. I know you don't have anything else more important than this at this point. So if you do, take a break, go resolve it, come back. But otherwise, you're just wasting everybody's time. So that exam grade was not good. That exam was not good at all. It was horrible. I mean, is that the right term? So crazy. I don't know. Like, it was very low. Very, very low. I know it's difficult, but at least, you know, yeah, it was not acceptable. It's not acceptable. So even though I added 12 points because we went over those questions, so whatever grade you had, you add 12 points, so that's your final grade. But I don't think I can keep doing that. Please change. You have a whole week now. This Monday is a quiz, the following Monday is an exam. So you have 2 weeks, almost 1.5 weeks. Please start studying today. And again, look, the way to study is, if there is a topic, understand the topic first. Understand the topic first in all its essence, then move on to the next topic. Don't read a whole chapter who talks about 20 different topics. You'll get confused. At the end, you won't remember anything. Take a single topic. If it is, for example, achalasia today, master that first, then move on. Then move on. Okay, then move on to something else. Please start studying differently. Don't study like in high school and college, where you have to read a chapter and you think the chapter is enough, and then you read. It's not about completion. It's not about completion. Okay, so it's never about completion of material. It is about learning. Stop worrying about quantity. Stop getting nervous about quantity. And guess what? Let's say you memorize, you understand 50% of the topics. You guaranteed 50% already. You already guaranteed 50%. And the other 50, you have enough knowledge to even guess on those. But when you study everything generally, and you worry about finishing a task, not understanding the concepts, you get nothing out of it, because everything then sounds the same. Who am I meeting today? So those few students today, please stay, and I want to quiz you. I got a lot of insight yesterday and the day before, talking to individual to students, so that's good. Hopefully I'm able to finish it by Wednesday with all of you, and then I'll give you some tips individually. What is your weakness? What's your strength? Because I'm writing all those. So work on those. And I believe you will change. I believe your grade should be dramatically changed. Okay? All right. I don't want to sound like Gandhi every day. If Gandhi is not your role model, whoever is your role model, I don't want to sound like those guys. But just please, this is sincere advice. I do care and you should care. Okay? All right. Now look, you understand, if achalasia is the LES, lower esophageal, so it's a disease of lower esophageal sphincter, correct? Can you remember that? Okay. GERD, it is a disease of lower esophageal sphincter, perfect. And in esophageal cancer, just a mass within esophagus. If that's where you start, that's where you start. Now, let's think about this. If LES is most of the time closed, you know when it says closed, it means abnormally closed, not normally. If it's a disease, it cannot be normal. So you have to have some understanding. When we talk about disease, what's the term for diseases? Pathology. Pathology does not mean normal. Physiology means normal. Path means abnormal. So if achalasia is abnormally closed LES, what conclusion can you make? Yeah, there is obstruction to foot flow. That's all. That's all. So what could be some causes? What could be some causes of LES being closed? Now, again, when I'm telling you closed, it's not 24/7 closed. It's two things. You can think of something being tightly closed, or you can say it doesn't open. It's the same thing. If a valve does not open, it fails to open, then it's the same thing. Or it stays closed. You know how I say it? The meaning is the same. It depends how you say it. So be aware of the terminology. Okay. It fails to open. Okay. Now, what do you think would be some causes?
Smoking, pressure,
No, let's not go to risk factor. Like,
causes?
yeah. What could cause the LES to stay closed?
Muscle.
Too much muscles.
Yeah.
So we can say one thing, hypertrophy. It could be LES hypertrophy. Common sense. If the LES muscle is so thick, so big, and you've seen guys, have you ever seen Arnold Schwarzenegger run? He can't run. He's so stiff. He has too much muscle. Same thing with ES. When you have hypertrophy, the lumen gets narrow and it doesn't open properly. Okay. The contractive force is too strong. Okay. Anything else? Nerve problem. Excellent. See? Now you're thinking. I don't even have to tell you. You can come up with your own conclusions. Then you will memorize the one that's the most common though. I'm only simply telling what's possible. What's possible. So of course, nerve damage. What are the nerves of the LES? Vagus. Okay. What? No, you're correct. Say it. Esophageal plexus, that's correct. Myenteric plexus, that's correct. Meissner's plexus, no. Orbach is correct. Just focus on myenteric plexus. Myenteric plexus means mye means M-Y-E means muscle. Muscles. Plexus means network of nerves. So the nerve that are within the muscle of esophagus is probably defective. So it's a defect of myenteric plexus. Okay, so let's write this down. Myenteric plexus are defective. Okay, that means the nerves causes what? The LES to open. The nerves will cause the LES to open. Okay, it will cause the LES to open, and it will cause peristalsis. So it is selective myenteric plexus only in the LES that are defective, or throughout the esophagus. Throughout the esophagus. Yeah. So throughout the esophagus, just remember that. Okay. Now, is hypertrophy more common? No. The underlying cause of the LES failing to open is what? Myenteric plexus defect. Done. I mean, that's not difficult. If you tell me, why can't you move? Why is your arm paralyzed? Oh, I think I have a nerve defect. Because it's the nerve that causes muscle contraction, right? For muscle contraction, we require three things. The first one is nerve supply or nervous supply. Second one is calcium. Third one is ATP. Three things. Only three things are needed for muscle contraction. And LES must contract to open. Okay? Huh? No, to open. So when the food comes in contact with it, it must contract and open up. Okay? So it will contract and open up. Okay. Unless I'm saying it wrong. But who knows? Right now I'm too pumped based on yesterday's result. Myenteric plexus. So if myenteric plexus are defective, that means the valve does not open, period. It will lead to what? Obstruction or dysphagia. At the end, that's not difficult. These are the two things you need to remember. If you can remember these two, the rest will be piece of cake. And you will tell me yourself now. Everything else. I don't have to tell you. Okay, so now, the thing is, who's at risk of myenteric plexus damage? Smokers, alcoholics, people who have viral infection, people who eat certain foods, and so forth, yeah. At the end of the day, we don't know the exact clear-cut cause. There's one thing that is for sure, age is related to this. Usually the patients are over the age of 50 or 40, 45 to 50, usually. Just know that. Achalasia is a disease of middle-aged adults. Okay? Achalasia is the disease of, so it's idiopathic. Nobody has identified exactly what caused myenteric plexus defect. It's not genetic. It's not genetic. It's acquired. That means environment is the one that's contributing to this. Okay? All right. So there you go. So now, age is the only thing I will care for. Over the age of 45, 40, same thing. Okay, yeah.
You said it's acquired, not genetic.
Mm-hmm.
So toss it out. Move up.
What does it say?
Genetics is this one.
What else?
It says these, but it doesn't say anything about being acquired.
No. Now, did you guys remember in genetics when we talk about multifactorial?
This is one of the
Okay, so what is multifactorial? What does it mean to you?
environmental and genetic components that do substance damage.
Say it loud.
You have a genetic predisposition. It's easier for you to get that disease, but it's not necessarily written.
Yeah. See, you know, you can have genetic components to something. It doesn't make it genetic. For example, a child of diabetic patients are at risk of getting diabetes more likely than those whose parents are not diabetic. Does it make sense so far? But it doesn't mean that this person will 100% get a disease. When we consider something purely genetic, you can have genetic component, but when you consider a disease genetic, that means there's nothing else needed. It is the enzyme is deficient, the protein is deficient, you will get it no matter what. So multifactorial Asra, meaning that they are acquired diseases. Acquired disease, some people are more at risk, some are less. If you're genetically predisposed, you'll get it most likely. Much, much easier than someone else. Okay? That's what it means. Yeah. So yeah, don't cross out genetics. It is correct. It has genetic component to it, but the disease is still acquired. Still acquired. Okay? Okay. Or let's think of it this way. Now, Caucasian people are at risk of what cancer? Compared to dark-skinned people. Skin cancers, right? So they're genetically predisposed. There's genetic component to it because melanocytes or melanin production in them is based on their genotype. But they are not, this is not a genetic disease. It's just they're more at risk because the product they produce is more sensitive to light. Okay? So if they protect themselves, if they do stuff, they might not get it. Okay? All right. But as far as genetic disease like cystic fibrosis, Sickle cell anemia. Once you have the gene deficiency, you can do whatever you want, you can't prevent it. There's no way to prevent it. If I tell you, for example, your car has no wheel, it doesn't have a wheel. There's nothing you can do about it unless you get a new wheel. But genes cannot be incorporated so far. Gene therapy has failed. Okay, so that's what genetics means. When we talk about, and it's important that, I'm glad she asked this question because this was, a lot of students had the same concern. And I want to clarify it now. When you talk about genetic disease, autosomal recessive, autosomal dominant, X-linked recessive, X-linked dominant, and then we talked about mitochondrial or imprinting, those diseases, if you have those things, you can't do anything about it. They will express themselves no matter what. Multifactorial is not a genetic disease. It has a component that's genetic. As long as the environment is silent, you will never get it. If the environment contributes to it, there's a chance you'll get it. Even then, it's not 100%. For example, the children diabetics are not 100% likely for them, even if they can eat 100% sugar, blah, blah, all abuses, they still might not get it. They still might not get it. But yet, they're more at risk than a person whose parents don't have diabetes. Okay, so my enteric plexus. Now, the question here is, so the LES is mostly closed. Now, you tell me, if LES is closed and the cause of that closure is my enteric plexus defect, and the most risk factor for this is age and viral infection, okay, especially drinking and smoking, all of this contribute to it because they can damage neurons, okay? Now, going further, what would you expect in terms of symptoms?
Aspiration,
Yeah, difficulty swallowing.
weight loss.
Do all of you understand why dysphagia? Yeah, of course. There's an obstruction. The LES does not open. Very good. Now, this dysphagia, do you think it is difficulty swallowing liquid, solid, semi-liquid? Initially, solid, and it's slowly, progressively. See, this is not a sudden disease. It's a progressive disease. Progressive disease. Please write it down if it's not in your books. Very slowly progressive disease. So slowly it will go to semi-liquid and eventually to everything. Just keep that in mind.
It's like all diseases are progressive diseases.
Mm-hmm. Yeah. Okay, so there you go. Now, if you're not able to swallow, is there enough nutrition going into your intestine?
No.
Are you absorbing enough? No. So somebody said what?
Weight loss.
Weight loss. Weight loss. Very good. Anything else?
You have regurgitation.
Regurg of undigested food. Regurg of undigested food. Why is that?
The food's not going down. That's why there's a blockage.
So if this is the esophagus, and here this is narrow, that means less food is going through and you're eating. And where does this food accumulate? In the lower esophagus. When would you have regurgitation? When you're running, when you're jumping, when you're laying, when you're hanging upside down, when you're swimming?
Laying up.
Only upon changing your position. Okay, so maybe at nighttime. Maybe at nighttime when you lay down. When you go to sleep, you might feel like food is coming into your mouth. Okay, isn't that common sense though? Again, if you focus on the underlying cause and underlying pathology, you don't have to memorize anything else. It's that simple and straightforward. So, so regurgitation. Of undigested food. Please, regurgitation. See, there's a difference between vomiting and regurgitation. Vomiting is usually food below stomach and so forth. In the esophagus is always considered regurgitation, not vomiting. You can use the term vomiting, that's fine. But be clear, medically it's not a good idea to use the term vomiting when things haven't gone beyond esophagus. Okay, so this food never went to stomach. If it never went to stomach, it never got digested. So it's undigested food. It will be the same thing whatever you chewed. If you chew a food and you spit it out, this food will look the same. Okay? I mean, it's common sense anyways. It's common sense. Sometimes you will see teeth marks in that food if you pay attention. Yeah? Yeah. Okay. It's still when you regurgitate, it crumbles and you will see it. Yeah. Yeah. Very good. Okay. Anything else? What else would you expect? If you can remember these three, you're very successful.
Excessive coughing.
Huh?
Coughing. Coughing.
Coughing? Possibly.
Or chest pain.
Chest pain, yeah. Now, let's move on to complications. So this is the chief complaint usually, the first symptoms.
Bad smell from mouth.
There you go, yeah. Odor. There will be odor, but the odor is not as bad because the food is, depending how long it's sitting there. Okay. Undigested food, if it sits, you know what, I don't know if you guys have seen, if you go to Caribbeans, I haven't gone, the only places I've traveled to since 20 years ago is, since I left Afghanistan, is only the Caribbeans and Europe. Europe is pretty modern. In Caribbean, when you see these water, what do you call the water channels? You know, what do you call it, stream? There's water that's flowing and there's water that's not flowing. The water that's not flowing is dirty looking and has bad odor and smell to it and flies and everything around it. Now, when you have food that is stuck in one area, what do you expect? Same thing as that dirty water. Now it's in us. Instead of flies, you'll have bacteria swarming it and eating it. And the bacteria, when they digest that food, they're going to release what? Factor that produces bad smell. Or gas that produces bad smell. Okay, so that rotten smell is not because of you, it's because of bacterial digestion most of the time. They started eating, they're feasting, they're celebrating. Oh my God, this guy's so nice. Give me so much food. But they don't know the guy has no option. Or the girl. It's mostly in men too though. Okay. Alright, so odor, add odor here too. Now, complication. What could happen over a long period of time?
Cancer.
Okay. Why? What kind of cancer?
Esophageal cancer.
Esophageal cancer.
Lower esophageal sphincter cancer. Adenocarcinoma.
Okay. Adenocarcinoma, let's write this one.
Smooth muscle.
Adenocarcinoma of
Oh yes.
esophagus, just keep it there. So, and then this, look, adenocarcinoma, just to kind of relate it, the esophageal cancer we're going to talk about, something called esophageal cancer, has two types. One is adenocarcinoma, and the other one is squamous cell. Squamous cell carcinoma. That's the two types of cancer. So that means achalasia puts you at risk of esophageal cancer. Okay, so you already know what are the risk factors for esophageal cancer, at least one of them, and that's achalasia. Why do you think achalasia will put you at risk of esophageal cancer? Irritation. And what does irritation lead to? Inflammation. And what does inflammation lead to? Necrosis, apoptosis. And what does that lead to? So when you kill your cells, when your body cells are dying, your body's not going to relax and just say like, oh, good job. What are they going to do? Like, let me repair them. When there's damage, there should be repair. The day we cannot repair, what happens to us? We die. So the fact that we have the ability to repair, we survive, we grow. Okay? So now, essentially, the same damage keep occurring and occurring and occurring. And then, this is not overnight though, it takes about 10 years or something like that, right? So, damage, repair, damage, repair, damage, repair. Essentially, your lower esophageal area, which is responsible for that repair, says, you know what? Forget it. I'm going to produce a lot more cells and much, much faster because I know it's going to get damaged anyways. So isn't it a good idea if I can produce 100 cells and 10 of them die? At least I have 90 left. Instead of producing 10 and 10 die and nothing left. And that leads to uncontrolled growth. Unsupervised growth. And that's cancer. Cancer simply means neoplasia, new growth, uncontrolled growth, anaplasia and dysplasia. Disorganized, uncontrolled growth. That's what cancer means. There's nothing else to it. So of course it puts you at risk of cancer. And that's a huge complication of it, of achalasia. Okay? Anything else? Difficulty? Okay, so now he's talking about dyspnea. Now dyspnea will only occur, of course cancer can put you that risk, but dyspnea will occur when you lay down at night time. You might choke in that sense. Because this food, you know, there's trachea and esophagus are paired structures. Where does trachea come from?
What is that?
Where does trachea come from? Foregut. We talked about this, right? So that means the two pipes used to be single pipe and it's separated. Okay? Now, that means at the end when they open, both of them into nasopharynx. Okay, let me just draw it for you. Let's say this is esophagus. In front of it is the trachea. They open to this area called nasopharynx. Here is a small, so this is trachea, T. There's a small flap known as the epiglottis, which is supposed to, or a cap, that's supposed to close the airways when you're eating. When you're not eating, when you're breathing, it will open up. That's why you cannot eat 24/7 continuously, because why? You won't be able to breathe. And you have to take a breathing between each bite or so forth, the bolus that you swallow. Now, at night, when you lay down, the food will regurgitate. Let's do it in red. It will regurgitate. It can accumulate where? In the oropharynx. And then, if the epiglottis opens, it can go into trachea. Yeah. It can lead to aspiration pneumonia. So let's put that. It can lead to aspiration pneumonia. But before it even goes that far, aspiration pneumonia means the food has to reach all the way into alveolar, which is far, far away down the line. It's possible, but it's not the first thing. The first thing, this food is going to, in your areas you have cilia and you have mucus. Immediately those cilia is going to start beating and push the food back into your oral cavity so you can swallow it. The whole idea of cilia is tracheal cilia, remember. We're not talking about esophagus, it doesn't have cilia. Tracheal cilia is supposed to propel this back out. Because airways are not designed for food, they're designed for what? Only air. Okay. When you have food, it can cause obstruction. It can cause severe dyspnea, so dyspnea is the first symptoms. Asthmatic-like symptoms are the first symptoms. Maybe it will lead to aspiration pneumonia, but in achalasia, look for asthmatic attack or choking at night. I'll wake you up. Look for those things. Okay. So what I'm saying is, if this is trachea keeps dividing into smaller, and smaller, but essentially it will become alveolar. For it to go that far to cause pneumonia is only infection of alveoli or lobules. To go that far, it takes a long time. So usually it will irritate right here first in the trachea, and you'll cough. You're going to choke. You're going to cough that food out. You don't want it to go that far. Okay? There's too much security down there. Immediately you will propel it. Okay. So look for the simple stuff. So complication will be first, nocturnal cough. What does the nocturnal cough means? Nighttime cough. Nocturnal dyspnea. Nocturnal choking. Nocturnal asthmatic attack. All means the same thing. Okay, so that's not difficult. Okay, good. So we made it that far. That's good. Let's go on with GERD. Let's go with GERD now. In GERD, LES does not close. It does not close. What's the normal function of LES? To open or to close? Close. Look, if a tube is designed for passage, why would you want to close that tube? It's not to prevent food from passing into stomach, but that should be normal. Backflow. Yeah. The purpose of LES is to what? To prevent acid reflux. It's not to prevent passage of food. Look, swallowing should be normal. You don't even need LES had you not had stomach acid. The purpose of the LES is to prevent food from coming back. Because we do crazy things, right? Sometimes you're laying down. Sometimes you're upside down. Sometimes you hang upside down. So you want food not to come back. So the purpose of LES is simply to prevent backflow. Think of it just like the heart valve. Therefore, if you want to prevent backflow, so most of the time, LES should be what? Open or closed? Closed. It should be closed 24/7. Unless food particle reaches to the door. Hey, I'm here. Please let me in. As soon as you swallow bolus, that contact of bolus with LES allows it to open. Otherwise, it shouldn't open. It makes no sense. So most of the time, LES should be closed. The only time it should stay open if you have food going down. Okay. Now, if LES fails to close, or partially closes, or stays open frequently, all of them means the same thing. Okay. At the end, that means there's a chance of acid refluxing. This is not a problem with swallowing, is it? This is a problem with regurgitation of acid. Okay, regurgitation of acid, reflux of acid. Okay, so that's the idea here is open LES leads to acid reflux. That should be U reflux, but you can add U instead of E. Now, what does GERD stand for? Yeah, it's a disease because there's an acid that's causing damage to your esophagus. And the damage is done because of acid coming from where? Stomach. GERD, G for gastro. Stomach acid, gastro. Esophageal, esophagus being damaged. Reflux because of the reflux disease. Okay. All right. Now, when acid comes, what is the epithelium of esophagus? Stratified squamous epithelium. What is the epithelium of stomach? Columnar. Now, why is it columnar? Why do you think in the stomach the epithelium should be columnar? Yeah. Look, the one thing we know that for sure for now, forget history or future, right now we know that stomach releases acid. That means you must store it somewhere. To store this acid, don't you need larger cells? Right? So squamous cells are flat cells. Columnar cells are tall cells. Which one can store more acid? So don't you think naturally that your stomach epithelium have to be columnar? You don't have to be told. You can make that conclusion on your own because you're intelligent. It has to be. There's no option. It has to be columnar, period. Don't even guess that. If you're buying a house and it has a dog instead of a garage, you're like, I'm not going to buy this because my car will not fit there. In order for you to park, you need a garage. You need space. So for this to release acid and store it, it must be large cells. Flat cells are nothing but except passage. Things to go through. Okay? Now, so that's one thing. Now, so one thing, these columnar cells, some cells are known as parietal cells, okay? Again, we're not going into stomach, but I will go into it after we finish with esophagus. Parietal cells release acid, HCl. Most of you probably know that. But they are not the majority of cells in the stomach. What are the majority of cells in the stomach? They're mucus cells. Mucus cells. These columnar cells are mucus cells. What do they produce? Mucus. And mucus is what? Bicarbonate. Wasn't bicarbonate the best buffer? Okay. Your stomach is designed to protect itself from acid because they have a lot of mucus cells which produces a neutralizing solution which neutralizes acid known as bicarbonate. Is esophagus capable of producing that much bicarbonate? No, because they don't have large cells to store it. Does esophagus produce bicarbonate? Yes. But it's not for neutralization of acid. It's for what? Lubrication. So the food bolus can move smoothly. Now, we'll talk about Zika syndrome. I don't know if you heard of that. Jorgensen's disease or scleroderma. Guess what? The mucus glands in the esophagus are damaged. So it's a dry esophagus. When you swallow dry food without fluid, how do you feel? Now, you can have semi-liquid food with all solution and everything, but your esophagus being dry. It's the same thing. So esophagus does produce mucus, but it's only a thin coat of mucus, not just like when you talk about, like, you put a solution on your face and your hand, lotion, not solution, lotion. That's how much mucus is produced because there's not enough room. And this can only cause lubrication, but not neutralization of toxins or acid. So if this acid goes from stomach into esophagus, don't you think it will cause damage to the esophageal cells? Because they're not designed to withstand high pressure from acid. They cannot neutralize this acid. So obviously GERD can cause problems. This acid reflux can cause problems. Okay? Now, do you remember the first day of classes when they talk about adaptation? Can you tell me some epithelial adaptation? Just give me the terms. Hyperplasia, aplasia, metaplasia, all of them depending on the environment. Now, it'll be common sense. Let's say, you know, who want to volunteer? Somebody, just volunteer. Okay. Mazen. Let's say Mazen is outside standing in cold, and I'm standing here. There's nice heat here, and then I send him outside. It's freezing. The thing for him is he needs to get a jacket. So now in this case, if the esophagus is not able to withstand, it's not able to withstand what? The acid. It has to eventually change itself. Unless you stop eating things that will cause dilation of this sphincter. So therefore, it will have to go through change. What kind of epithelium can protect itself from? An epithelium that produces mucus, and that is columnar. So that means the lower esophageal epithelium will change from squamous to columnar. And you can call this gastric metaplasia. Why using the term gastric? Because the epithelium of the lower esophagus is becoming similar to stomach epithelium. Gastric metaplasia. Gastric metaplasia. The crazy thing is there's nothing illogical about medicine. It's just unbelievable. It's just, as I said, if you just focus or you find a way, sometimes it's difficult to focus, just find a way. Okay, so it's common sense that acid reflux will cause, now we're not talking about acute reflux, right? We're talking about repetitive, recurrent, chronic acid reflux. We're not talking about 1 day. We're not talking about 1 week. We're talking about recurrent, okay? Recurrent, chronic exposure of lower esophagus to acid. Eventually the esophagus will say, you know, you don't listen. Seriously, you don't get it. I'm not going to listen to you no more. I'm independent. Each cell is independent. I'm going to do what? I'm going to change myself to a cell that can withstand this pressure because you keep harming me. Even though you hurt, you don't do anything about it. Even you have chest pain, you don't do anything about it, or heartburns. Eventually the esophagus is going to say, hell with you, excuse my language. I'm going to change myself because you're not going to do it for me. I don't expect you to do because you have failed over and over. So, and I will change to, and this condition, when it changes from squamous to columnar, is known as Barrett's esophagus. Barrett's esophagus. Is it 2 T's or 1? Yeah, I think it's 2 T's. Okay, Barrett's esophagus. It should be in your book. So Barrett's esophagus is not a disease. It's a histological finding. Yeah. It is nothing more than metaplasia. That's all there is. Don't consider it a disease. It should never be discussed in the isolation of GERD. Okay. Barrett's esophagus simply, like, you know, if your skin in one area is rough and thick because you're doing construction and stuff, same thing. That's what it is. It's what you see under microscope. That's all. It's given the name Barrett's esophagus. It's a complication of chronic acid reflux. Okay? So that's all there is to it. This term is only applied to when you see the esophagus, it doesn't look like the original esophagus, it looks like stomach. When the lower esophagus starts looking like stomach, you call it a different name. And that name right now is chosen to be Barrett's esophagus, so you're going to memorize that. Tomorrow, if you do something else, good for you. But today, you're going to have to call it what it's called. Okay. Very good. Okay. Now, let's go to, if you know this much, what if this acid reflux? Would it hurt? Yeah. And we call that burning, right? It feels like burning pain. Heartburns, yeah. Why you call it heartburn? Yeah, it's actually chest pain. So I'm going to put a chief complaint here, chest pain, okay? Chest pain. Just remember that. You'll feel chest pain. Why chest pain? Where's the esophagus located? In the thorax, not in the abdomen. you should never have abdominal pain with GERD. With achalasia, you should never have abdominal pain. Esophagus will always give you what? Chest pain, chest pain, chest pain, chest pain. Because it's located in the chest. Where does it end, esophagus? By the diaphragm. Yeah. T10. 8, 10, and 12. Don't forget that. Vena cava.
I ate 10 eggs at 12.
Oh,
I ate. Say it.
10 eggs at 12.
Okay. Exit E for esophagus, right? And 12,
For aorta.
thoracic aorta. Yeah. T12, T thoracic aorta. So, anyways, it will present as chest pain. Now, you know what? If you go to emergency room with chest pain, the first thing they should think of what? MI.
Oh.
MI or angina. Okay. Yeah, you could be smart. If it's somebody's young, you say, oh, unlikely that you will have heart attack. But as I'm saying, the most devastating news is what? Heart attack. So always consider that. Even if it's a mild chest pain, even if you don't think, just think about it. It's a good idea to think about it, at least for the exam purposes. But now, in reality, GERD is a disease of young people. It starts in young age, in 20s, and at that age, you should not expect heart attack. I know my brother-in-law, he's like, oh, I have chest pain. He was so nervous. So, and he loves sushi. He ate too much. So, and the other thing is when you eat too much, we'll talk about risk factors. So chest pain. Now this pain should be what? Burning in quality. And Nina? Possibly, yeah. Increasing with food. Positional, there you go. When you lay down, it should increase. Now, chest pain caused by MI or heart attack is non-positional. Non-positional. Doesn't depend when you lay down, upside down, do this. The only thing, maybe it's related to running. Exercise, maybe. But it's non-positional. Whereas GERD is positional. It's not severe pain. It's dull, low quality, like 3 out of 10, 4 out of 10, burning type of pain. Those of you who had it, you would know. I mean, I had it. I'm sure each one of you had it one time. Maybe you don't call it GERD. You at that point, acid reflux, acute acid reflux, right? Okay, anything else? What else would you expect? If the LES fails to close most of the time, that means it stays open most of the time. Don't you feel like regurgitation should be there? Yeah. If the valve does not open, that means food can regurgitate, especially when? There you go, laying down. Nighttime. So now you will have nocturnal dyspnea. Now the dyspnea with GERD is more than achalasia. With GERD, the dyspnea is more, and this is known as chemical asthma. Okay, so the nocturnal dyspnea in GERD should be called chemical asthma. Not allergic. Chemical, what's the chemical? Acid, HCl. The HCl, when it reaches to your trachea, it will cause irritation, and it will cause spasm and dyspnea. Okay? So chest pain, which is burning in quality, dull chest pain, okay, does not radiate anywhere. And then you have nocturnal dyspnea. Anything else? What if the food or whatever regurgitated in your mouth? How would you feel? Possibly. There you go. Sour taste. You will have the sour taste in your mouth of food. Acidic taste to it. Yeah. Sour taste. Okay. Yeah. So that would be exactly the chest pain. That would be burning in quality. Now, MI chest pain is sharp, like a knife, squeezing, pressure, like you put a huge rock on your chest, and you have difficulty expanding your chest because it has to do with oxygenation, right? This chest pain is burning. Okay. I don't know if you guys seen those commercials with Tom's, and then there's this big monster coming in, he's burning, and the other thing comes and hits him, blah, blah, whatever. So there's always burning with this. Even the commercials are burning. Okay. Now, complication. What do you think of complications?
Cough a lot because of gastric aspiration.
Huh?
Gastric aspiration is going to cause coughing.
Yeah, so nocturnal dyspnea, cough, yeah, we'll keep that here.
Complication cancer.
Barrett's esophagus is complication. That's one. Anything else?
Cancer.
Carcinoma again.
Adenocarcinoma?
Yeah.
Anything else? Stricture, there you go. Esophageal. I mean, all of this makes sense. All you have to memorize, the LES does not close properly. That's all. What's another term for failure of closing of LES? If something is not doing its job, what do you call it? Incompetent. Yeah. Insufficient. Incompetent. Loose. Many terms you can use. As long as you can picture it doesn't close properly.
What if causes asthma?
Yeah, that's what we said, nocturnal dyspnea or chemical asthma. Chemical asthma, chemical asthma, chemical asthma. Okay. Anything else? Yeah. Absolutely. Yeah, aspiration pneumonia. But it has to be, in both cases you can have aspiration pneumonia. It's more likely with achalasia because there's enough food going. But in GERD it's mostly acid, so yeah. Very good, very good. Yeah. Yes, sir.
Yeah, wouldn't it also increase the pressure in the stomach because the LES is constantly open? So wouldn't that cause abdominal?
Actually, if it's closed, it creates more pressure. Yeah. If it's open, it less pressure. Yeah. Now, the pressure that can be caused in the stomach is if air and everything is trapped and it gets nowhere. That means pyloric sphincter and LES are closed at the same time, and the stomach is contracting. Food is not moving this way. This way, it creates more pressure. If it's open, no pressure.
But if it's open, wouldn't it have more air in the stomach?
Yeah, but it can leave back. See, air is based on diffusion. It will always go from high to low pressure. As soon as the pressure in the stomach equals esophagus, nothing would happen. Yeah. Yeah. Anybody else? No?
Is there any malodor because of that, Dr. Mooney, or no?
Now, what you can think of, these people might have bad teeth. Okay, so they're at risk of dental cavities. Why? Because acid causes what? Erosion of bones, right? Now, can you give me an example of something in our diet that is damaging, that's very acidic, that's damaging to your teeth? Coffee, yes. Citrus, yes. More than that, something that everybody drinks a lot. Sodas, especially Coke and Pepsi. You know, those of you who still have your wisdom tooth hiding somewhere in your pocket, put in a bottle of Coke or a glass of Coke for one night, check it out tomorrow night to see what happens. And that will tell you what you should you drink Coke or not. Okay? So yeah, these people are at risk of having dental cavities. Okay? All right. Anything else? Now, what is this gonna, so this, fine. Barrett's esophagus, okay, we talked about this. Now, before I go to cancer, adenocarcinoma, again, it's here, esophageal cancer. We'll discuss it there, right? How about esophageal stricture? What does that mean? Yeah. Now, have you guys ever seen, you know, like next time you cause aberration of your skin or some sort of scratching of your skin to areas and hold them like this. Not long, okay? Just for about exactly 10 minutes. No, that's too much. 30 seconds. And then pull them apart. See how you feel. That means you have factor in damaging tissue that will cause repair. And the skin of your two fingers will stick together. What I'm telling you, inflammation always puts you at risk of stricture. The tissue, when it's getting repaired, actually getting repaired and glue things together. So stricture in this case is almost like achalasia. Almost like achalasia. That means the lower esophagus will actually become narrow. That's esophageal stricture. Stricture means narrowing. because of gluing and sticking of the esophageal tissue that's being repaired. So could GERD present like achalasia? Of course. At that point, you're not going to be worried about reflux. No more reflux. The history of reflux. Now you have difficulty swallowing. So in progressed, advanced GERD, you should expect dysphagia. Dysphagia. The patient should have a history of heartburns. Now he has difficulty swallowing. Does it make sense? Yeah. So just because patient has GERD, you're like, oh my God, they can never have achalasia-like symptoms. Yeah, they can. Yeah, they can. Okay. Let's move on to cancer. Now, here is the esophagus. What time is it anyways?
It is 9:17.
Okay, so let's finish this and we'll take a break. Now, there you go. When you talk about adenocarcinoma, just in general, esophageal cancer or carcinoma, esophageal cancer or carcinoma, is cancer of what? It is cancer of esophagus, but what part of esophagus? How many layers does esophagus have? 3. Can you name it for me? Serosa, muscularis, and mucosa. Now, cancer is this cancer of serosa? The origin of this cancer cell, is it serosa? Is it mucosa? Is it submucosa? Or is it muscularis? It's strictly mucosa. Thank you. Strictly mucosa. These are epithelial cancers. The most inner lining of esophagus is what leads to cancer. And that should make sense to you too, because if GERD puts you at risk of cancer, what part of esophagus is exposed to acid? The innermost layer or the outermost layer? Yeah. Serosa never comes in contact with this. And the smooth muscle, muscularis, never comes in contact with this. It is only the epithelium, so it's common sense again. Same thing with achalasia. Food is stuck inside the esophagus, so the superficial layer, the inside, the innermost layer is in contact with food. And that's the layer that gets irritated and inflamed and eventually cancer. So, as I said, something we don't think, but it's straightforward. You just have to take a moment and think and connect things, that's all. So number 1, these both of them are mucosal cancers. Mucosal cancers. So if it is mucosal cancer, so the smooth muscle is thicker, right? And then let's say the serosal layer is technically thin. I'll just use red. Now if there's a mass, did I say serosa? I meant mucosa, sorry. If there's a mass of the mucosa, is it going to go into the wall or protrude into the lumen? So this mass will be always luminal mass. Luminal mass. If you have a mass, it's almost like eating a grape that gets stuck in your esophagus. So esophageal cancer will give you what? Obstruction again. Obstruction. So esophageal cancer causes what? Obstruction of food flow. That's all.
Blood in the stool from this?
Possibly. Yeah. So nothing more than obstruction. Again, obstruction. Usually it's circumferential. You know, you get it like this, all around the mass. So again, it decreases the size of the lumen, the diameter of the lumen, so it leads to obstruction. Okay, so that's good. Now, would it be fair for you, would you remember this when you talk about adenocarcinoma as a complication of GERD or achalasia? At the end of the day, it leads to what? Similar symptom like achalasia, obstruction to food passage, or dysphagia, dysphagia. Good? Now, adenocarcinoma, adeno means adeno. This term known as adeno means gland. The term adeno means gland. Gland is a collection of cells that are supposed to secrete things. Glands has only one purpose, to secrete and store and secrete. You don't expect glands in the esophagus, do you? No. The only time you'll find glands in the esophagus if there's something abnormal. When would the esophagus need to make more gland?
When it's dry.
Yeah. When it needs to protect itself. From acid reflux. Okay, so that's why adenocarcinoma will be always in the lower esophagus. Memorize this. Adenocarcinoma is always in the smooth muscle area of the esophagus, or the lower 1/3. Adenocarcinoma is always closer to LES, always. So that's adenocarcinoma. Squamous cell carcinoma is supposed to be always higher up. It's always in the upper esophagus. Squamous carcinoma is always going to be where? In the upper esophagus. Adenocarcinoma, lower esophagus. Squamous, upper esophagus. Okay? Superior is squamous. Adenocarcinoma, much lower. It's because adenocarcinoma is caused by things that cause damage to the lower esophagus, where there can be glands, extension of the gastric mucosa there. Yeah.
So would there be present in lower part?
Yeah. Barrett's is a look. Good question. Now, first, when you have damage to esophagus, there will be what? Inflammation. Good? Inflammation and repair. And then this will progress to Barrett's. Barrett's will progress to what? Cancer. Okay? Therefore, let me ask you now, Yasser, that if somebody has GERD and you discover that they have metaplasia or Barrett's esophagus, what are you going to do for the next 10 years? Sure, what are you going to do as a doctor? Watch them, monitor them. So you will indicate annual endoscopy. Check the lower esophagus every year to see if it's progressed or got better. Why? Because it's at risk of what? Esophageal cancer. But let me give you bad news. Very, very bad news. Esophageal cancer is so aggressive. Their 5-year survival rate is 5%. Only 5% of the people survive after their cancer has been diagnosed. 95% die. Bad prognosis. Esophageal and pancreatic cancer have a very worse, poor prognosis. Okay, so you have to monitor Barrett's esophagus, just in case, because this person's at risk of what? Esophageal cancer. Did anybody have esophageal cancer, a famous actor or something? Somebody famous? Patrick Swayze, right? He died of this or something like that. I remember somebody. Was this or pancreatic, one of them? Okay. So are we good so far? Do you understand? Before I even go more, now tell me this, guys. If somebody has esophageal cancer, what would be they complaining of? Dysphagia. Possibly regurg.
Weight loss.
Weight loss is essential. Weight loss. One more thing. Fatigue. Now you can say in this case regurg.
Has some blood in it.
Very good. You can say hematemesis. So they will actually regurgitate or vomit blood. It's possible. Not a lot. But not a lot. I'll put fatigue first, because when they lose blood, they will have iron deficiency anemia. Iron deficiency. They lose blood. Okay, so that's typical signs. Now, let's talk about its complication. Complication of adenocarcinoma or squamous carcinoma are two different things. Now, know that adenocarcinoma is in the lower esophagus, squamous is in the upper esophagus. So complication will be based on where is the location of the tumor. For adenocarcinoma, what are the possible complications? This cancer can actually extend into what? Okay? And then what? What would happen? It's cancer, it will spread, so what will happen to the stomach? Would it not work properly? What will happen? It wouldn't affect the stomach, because the stomach is too big. If it goes that far, invades the whole stomach, it's death anyways. By then it's too late. So the most likely complication of adenocarcinoma is arrhythmia, because it's related to the heart. Yes. Yeah.
left ventricle.
Mm-hmm.
So the pressure is affected.
You see, again, why did we do the anatomy? Remember that? Esophagus is sandwiched between what? The lower esophagus, at least the lower esophagus. Between left atrium and aorta. Very good. So it can cause aortic obstruction, vena cava obstruction, and heart compression. And if it goes extend downward, it can cause damage to the diaphragm. So it can cause a variety of things. Now you know why it is so lethal. What are the most vital organs of your body for survival? Not the brain, right? Heart and lungs. Heart and lungs. So if those are damaged beyond repair, death is imminent, right? Yeah. Okay, so adenocarcinoma will give you most likely arrhythmias and things like that. Okay, or if it's vena cava, let's just put it this way. If it obstructs or compresses, vena cava is more likely because vena cava is slightly softer. Aorta is rigid, so it's less likely to be compressed. Okay, so if it compresses inferior vena cava, what do you think would happen?
Thrombosis.
Thrombosis, varicose vein, yes. But at the end of the day, imagine this way. Think about it this way. So this is vena cava, right? What is the job of inferior vena cava? To return blood into the heart. If it's compressed here before the heart, can you bring blood into the heart? At least not the same amount. So what happens to blood? It starts pooling. When it pools, where is it going to pool?
Edema.
There you go. Liver, spleen, and feet. So you will have peripheral edema, liver congestion, splenic congestion. So that would be typical. Whenever you think of edema, think of vena cava. In this case only, a vena cava obstruction. Now, if it's aorta obstructed, that means your lower extremity is not receiving what? Enough blood. So blood is going to pool where? So upper extremity will have what? Hypertension. With arteries, never edema. No. Because they don't leak. Yeah. So hypertension in the upper extremities and CNS and headaches. Hypotension in the lower extremities.
Second turn is coarctation.
This is like coarctation of aorta. Increased pulse is where? Upper extremities. Lower pulse is where? Lower extremities. Isn't that common sense though? As soon as you obstruct aorta, blood flow to lower extremities will decrease. If there's less blood going to your lower extremities, less heat, your feet will be cold to touch. No pulses, weak pulses. It doesn't have to be no pulses, that's extreme, okay? Weak pulses. Weak pressure or low pressure. Yeah. So that's why aorta is protected. It's rigid, it's rare. But it will most likely cause arrhythmias, invade the heart tissue. But it depends again. That's what I'm saying. If it goes beyond esophageal cancer, when it invades those organs, it's done. Say bye-bye. Yeah. Okay. Now, so that's for adenocarcinoma. But there's one more thing. So this was inferior vena cava. If that's obstructed, you know what are the symptoms? If it is aorta, because you're a smart genius student, because you're my student. I want to see myself in you. That's just, I'm going to take credit. Sorry. No, honestly, you are. You just have to give yourself credit. I'm telling you. Doesn't it bother you that you know so much, you have so much tools, and yet you're not able to translate it? It should bother you. You have incredible potentials. You have incredible potential. It makes me sad. And it should make you cry, guys. Seriously. So, aorta. Now, diaphragm. If diaphragm is affected, yeah, dyspnea, and essentially death. But there's one more thing. Remember we were talking posterior mediastinum. A smart student yesterday asked me about posterior mediastinum, so I'm not going to put them on the spot, but anyhow. Now tell me, what is the posterior mediastinum? What are the structure in the posterior mediastinum? Inferior vena cava, aorta, esophagus. So it's esophageal cancer. Anything else?
Vertebral body, spinal nerve,
Sympathetic chain, sure. That will cause instability like incontinence. Look, if you compress the sympathetic chain, it will cause incontinence, maybe urine incontinence and stool. Or recurrent laryngeal nerve will be not adenocarcinoma, will be squamous. Okay. One more thing. thoracic duct. I love it. There you go. That's the most important one because it's softer. It'll be the first one to be compressed.
That will cause edema.
That will cause edema. Yeah. More than vena cava, it's more thoracic duct. Now, thoracic duct. Who wants bonus? If you know anything about thoracic duct, you want bonus, tell me. Go for it, Nina. Sorry. Huh? It drains lymph, yeah. Anything else? What part of the body is drained by lymph? Thoracic duct. Okay, the entire lower extremities, okay? So let me just show you. Let's draw. This is Nina, because she's the one who said, sorry Nina, just for simplicity, okay? Excuse me. Now, which is your right? Is this your right or left? For you? Okay, so that's left, right? Okay. The area that I'm going to cover, blue, this is drained by right lymphatic duct. The entire body, the rest of the entire body is drained by who? Thoracic duct. So whatever I cover in red, this area is drained by who? Thoracic duct.
So we'll have edema only that part.
Okay, thoracic duct. Which means thoracic duct essentially will get also some lymphatic drainage from the upper body, but if it's blocked in the thoracic area, so upper extremities, lower extremities, everything will be affected. So you'll have generalized edema. Remember, it drains into the jugular bifurcation here. So it comes from here, the thoracic duct. And it will drain here. Okay. Therefore, obstruction of thoracic duct over here in the thoracic area, the head and neck will not be affected. Upper extremity will not be affected. It's only the lower extremities, because they will join after the obstruction. Okay? So you will have, again, edema of your legs and abdomen. Okay? So look for that. Now tell me one more thing. Edema of the abdomen. What do you is there a term for edema of the abdomen? Ascites. Look for that. And ascites can put you at risk of what? When you have fluid that is stagnant, that's not moving. Infection. Infection of the abdomen is called what? Peritonitis, yeah. Peritonitis. Okay, peritonitis. And peritonitis is an emergency, right? It better be, because you have vital organs in the abdomen. Can you name some organs in the abdomen? Liver, pancreas, spleen, has a lot of blood, yeah. Stomach, duodenum, intestine, large and small, gallbladder, kidneys, adrenals. Adrenals. I thought they're emergency, yes. Anything else? Ovaries and females, yes. Because abdominal pelvic area is the same. It's one opening, one cavity. It's extremely sensitive. So peritonitis is actually emergency. You have to be careful. Treat them immediately. Now, what could be the symptoms of peritonitis? There's actually tenderness. Guarding, excellent. Guarding. What's guarding? Good job.
You can't touch your stomach, it will push you away. Basically, how much painful it is.
Yeah. When somebody touches your abdomen because it's painful upon touch and it becomes rigid, it's like, don't touch me. That's guarding. So that your abdominal wall guards itself from being compressed, because compression will cause pain. You know, like if you have a swelling here somewhere and somebody touches, like, oh, don't touch me. It hurts. Your stomach does that. Not the stomach, your abdomen, abdominal wall. That's guarding. It becomes rigid. It doesn't want to be compressed, because when you compress, it will hurt. Anything else? Fluid, shift. You will hear fluid being moving, shifting with changing of position. Anything else? Distension, yeah, of course. Abdominal distension, yeah. Anything else?
Constipation.
Hmm?
Constipation.
Decrease bowel sound. Now, when your bowel is moving, look, if your abdomen is sensitive to touch, shouldn't your bowel be resting then too? If your bowel is inflamed, intestine is inflamed and swollen and it hurts for each movement, shouldn't it be resting? Yeah. So if it's resting, that means no bowel movement, no sounds. So there should be decreased bowel sound. And again, all of this is logical. You don't memorize it. You just try to understand it. What should happen? What do you expect to happen? You focus. You make the decision. Okay? You make the decision. This is what I expect. This is what I expect. Okay. Let's move on. I'll keep it. Let's take a quick break. Okay, let's take a quick break.